Welcome to the NWA-ETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, I'd like to give a big thank you to Dr. Ann Melvin for agreeing to come do a talk for us. I invited Ann, who is one of the clinical directors of the PEDS HIV program here at Seattle Children's. And Ann's going to give a talk today on the workup and management of HIV-infected internationally adopted children. So thank you, Ann, and I'll turn it over to you.
Great. Well, thank you for inviting me and the chance to be here. So I have been working at Seattle Children's HIV program since the early 1990s and have seen incredible changes, and of course, as the rest of you have, in the management of children. We were, because of the improvement in the prevention of transmission from moms to babies, we've seen very few new infected children, and our children were basically aging out. So around 2004, 2005, I think we had a clinic of about 30, 35 kids there at Children's. And then in 2006, we started seeing new children coming in, both from families who were immigrants from countries where there was higher seroprevalence of HIV, but also these new internationally adopted children. So it's become a large part of what we're doing, and I know many of you probably are aware of children in your communities that have these as well. So that's the reason for giving this talk today, and I hope it's helpful. So what I hope to cover is the initial workup of an HIV-infected internationally adopted child, some of the common medical issues that we've seen in our kids, and then some of the management challenges that we've seen. This is what you might find. Your next patient is a 6-year-old boy who was recently adopted by a U.S. family from an orphanage in Ethiopia. They got home 2 weeks ago. They know he's HIV infected, and his current meds is Triimmune Junior. He takes 1 tablet twice daily. The family knows very little about his past medical history. They know that he's been on ARVs for about 2 years. They have paperwork that has a CD4 count from a year ago that was 754. He has paperwork from the consulate saying that he was cleared for TB, and here you are, and where do you start? This happened to me in 2006, and I was not particularly prepared to handle it. So just for your information, Triimmune Junior is a combination tablet with 100 milligrams of nevirapine, 12 of stabutene, and 60 of lamivudine. So where do these kids come from? There are approximately 8,600 internationally adopted children in the U.S. in 2012, and this is sort of the countries of origin for uninfected children, or not divvied out, where China and Russia are huge contributors. More are coming from Africa, and Ethiopia is the largest country contributing adoptees there. And then in our clinic, as I mentioned, it started about 2006, and we've had about 5 to 10 a year since then. And so now we have about 60 children in our clinic that are internationally adopted. And so the vast majority are coming from Ethiopia, about 70%. Overall, about 90% from Africa. We have some from Ghana, Uganda, South Africa. We've had a smattering from China, Southeast Asia, and then getting some more from Ukraine and Russia, Latvia, some of the Eastern European countries. I could not find any data on what the overall numbers are, but given the numbers in our clinic, my guess is that this is a phenomenon that's not limited to us. Because we also do primary care for most of these kids, there's a lot of advice out there on what to do for the workup, and so this is a recommendation of what we do. We check their vision and hearing. Immunizations remain a challenge because you can't really trust their vaccine records, and so we follow the catch-up schedule from the Advisory Committee on Immunization Practices has a schedule for catch-up of vaccines. We do a lot of titers, particularly things like polio, because many of them, even if they don't have evidence of that, I think they probably had just been polio vaccines through the mass campaigns that come through with that. We also check titers for vaccines that you wouldn't need to give, like varicella, hepatitis A, if they already have evidence of past immunity. You need to be aware that they may have been given measles vaccine, but not MMR, so even if they're measles immune, that doesn't mean that they are also immune to mumps and rubella, so we just give the requisite 2 doses of MMR usually. Many of them come with dental issues because of concerns about their nutritional status. We check for iron deficiency. If they're from Africa, we check for sickle cell. We do lead levels, check their thyroid status, particularly if they're stunted, and then just some routine lab work to see sort of where they are. We also make a referral to the UW Adoption Clinic and often trade that workup with them because they have a lot of resources for families, both with internal and internationally adopted children. So I find it's very helpful for them, some things that we can't offer, and because it's not really what what we do. And then there's the infectious disease screening, which we try to get stools for 3 different samples for open parasites. That increases the sensitivity significantly. It's hard sometimes to get people to do this. We do stool for Giardia antigen. We don't do the cryptosporidium antigen because it's done in our O&P exam, but if your site doesn't do that, then you would want to add the cryptosporidium antigen as well. If they have eosinophilia or chronic diarrhea, we just sometimes do empiric deworming even if we don't find anything in the screens. Even though they come cleared technically for TB, it's not entirely clear what that means to me. One of the families said that their method of getting sputum on these kids was to run them up and down stairs until they got tired and coughed, and then they got the sputum from them. So we're not exactly sure what that means. So we do screen for TB. If they're less than 5, we do with TST. If they're over 5, we use quantiferon gold. And then the recommendation is that should be repeated in 6 months if negative. That was the recommendation for the PPD. I'm not exactly sure why you would need to repeat the IGRA, so we don't always do that, but we do repeat a TST in the younger kids. We check for hepatitis A, B, and C serologies. That's not in the standard panel for all the recommendations, but because of their HIV infection, they're at increased risk. To check for syphilis, you would want to do an RPR and a treponema-specific test. Not on the standard panel from the CDC are toxoplasma and HSV, but we tend to do those just again because of their HIV infection, and we have a lot of kids that come with recurrent HSV, and it's nice to know their serologies. It also helps you pick up if there's evidence of sexual abuse, if they're HSV2 positive, which they should not be as children. And then the other workup is according to their signs and symptoms and what else are led to by how they present. HIV workup, obviously, we do lymphocyte subsets, we do a viral load, HIV serology, and then review their antiretroviral doses, and then access to medication, because one of the things we found is many of them come on doses that are too low, and also that they come on these nice tablets like this Triimmune Junior, which is 1 tablet once a day, which we don't have actually in the US, and so now you have to tell families that, well, not only are you going, if they don't, and this is a chewable, so if they don't swallow pills, you're going to liquids, and now you're going to 3 instead of the 2, and so you need to make sure they actually can get the medications. What do we find in these kids? So they're actually very healthy by and large. We've had a lot of tinea. About 30% of the kids come with either tinea capitis or tinea corporis, mostly tinea capitis. And interestingly enough, it's usually Trichophyton violaceum, which is a species not unique, but common in Ethiopia. So and they seem to be a little bit harder to clear with the standard Griseofulvin. So many times I end up having to use terbinafine in them. A lot of molluscum. About 30% come with some kind of parasites, almost always Giardia. And so we do check for that. And often it can be really hard to treat. We've had several situations where we've had to do multiple rounds of treatment for Giardia. A lot of otitis media and some hearing loss, chronically draining ears with perforations. Nutritionally, they're usually pretty good. Very little evidence of severe malnutrition at the time we see them in terms of their height for weight, but about 30% have come with more than 2 standard deviations below their height for age, so stunted, which probably reflects both the HIV that they've had untreated early on and also their potentially past malnutrition prior to reaching the orphanage. We've had about 10% with latent TB. Have only had 1 kid with MDR, a teenager with MDR TB who had a history of multiple past treatments and then had increase in abdominal disease. Hep A, about 90% come with evidence of past immunity, so it must just run through these orphanages. We've had a couple that have actually presented with acute Hep A at presentation. One of the early kids, before I was really thinking through all this as clearly as I do now, when I did her initial screen, she looked beautiful, and her ALT was 700. It's like, oh, well, that's interesting, and she had acute Hep A. We've seen actually no Hep C kids, although I think it's probably just our small population, and we have about 3 or 4% that have chronic hepatitis B. What they look like from an HIV perspective, most of them again look pretty good. 90% have had CD4s greater than 25%. We've only had a few that are really significantly immune suppressed. About 90% are on combination antiretroviral therapy at the time of their adoption. Most of them are on an NNRTI-based regimen, and the most common regimens are zidovudine, lamivudine, nevirapine, or stavudine, lamivudine, nevirapine. Some of the older kids have been on efavirenz, and some of the younger kids have come on Kaletra-based regimens. That's the only protease inhibitor that we've seen these kids come on. And as I mentioned, they're often come on these really nice combination tablets, which we don't have access to here for these regimens in the US. What are some of the challenges that we face? Well, one is, are they actually HIV infected? So the first kid that presented had a detectable viral load, and so we knew she was infected and went on that. The next kid that I saw was on meds and doing well, and I didn't realize sometime down the road that I actually didn't have proof that she was HIV infected. And so we started doing serologies on all these children. If they're older, if they're younger, then we need to do DNA PCR. And we've had a couple of infants who, one actually came on medications who turned out not to be infected. A couple that were just called infected, so the families adopted them thinking they were infected, but they indeed were just had maternal antibodies still left over from exposure. And then we had an older kid who was age 6 who was not on medications, who again came billed as infected but was not. So the situation that we've run in occasionally as well is even in kids who are younger and probably started medication early, is they can lose their serology. So they can look seronegative and that they're not, and so that in that case we do DNA PCRs to try to confirm diagnosis. Their previous antiretroviral history is very uncertain. It's often unclear what they were on, when they started, what other regimens they've been on. And they've had no previous viral load testing, so you get no previous RNAs. And about 20 to 25% have come with detectable virus and resistance of presentation. Common mutations are the ones to nevirapine, and then 3TC, because they're all on lamivudine, and then a smattering of thymidine analogs. So families come having to deal with all the HIV issues and all the medical issues, and then we say, oh, by the way, we need to change your medications, and oftentimes because of access to new medications, we offer them a clinical trial, and it's a lot for them to handle up front. But the really nice news is that these families are incredibly attentive, and the kids are very adherent, and once you get them on a regimen that works for them, they do wonderfully. So once we get them on a new regimen, then 95+% of them remain undetectable, and they're doing very well. We often have the challenge of what if they're on a PI-based regimen. So that's a second-line regimen in most international settings, except if you're an infant. That now the Kaletra-based regimen is recommended in South Africa and some other countries early on. And so if they come on zidovudine, 3TC, and Kaletra, well, that's kind of a half of a first line and a half of a second line. So did they fail a previous NNRTI regimen? Or were they exposed to an NNRTI for PMTCT? We don't know. Or did they start on that as their original PI-based regimen just per local ART guidelines? And without any history, it's really difficult to know that. So we've handled that a variety of ways depending on the situation. Some we've gone as far as trying to pull their PBMCs to see if we could find any resistance. That's helpful if you find it. It's not necessarily helpful if you don't. Some we base it on their knowing what the local guidelines are and making the assumption, for example, if it's a 2-year-old from South Africa, they probably were just started on a PI-based regimen. And oftentimes we just leave them what they're on or modify it to make it easier for the family. But for example, going from Kaletra to atazanavir, ritonavir, so it's once a day, because you just don't know. You don't know what their past history was. In summary, international adoption of HIV-infected children is increasing. At least it's been our experience. Like I mentioned, we don't have national data, but I expect that this is something that's being seen nationally. It's important to conduct the full evaluation recommended for international adoptees in addition to their HIV evaluation. In general, the children have been well with few major medical issues. We have very little previous history. Most of them are doing very well in their current regimen. They have good CD4 cells, and then about 25% have detectable viral loads and resistance to their current regimen. So some of the resources that are helpful, there's the Yellow Book, which is the CDC sort of travel, has a section on both of parents going to countries to get their kids what they need to do up front. For example, it's important to make sure if you get, we often get called up front, we're interested in doing this, what recommendations do you have? Make sure the families all have their Hep B and Hep A vaccines, because they won't necessarily, particularly the Hep A. And that also has recommendations for management and workup of international adoptees. There's also the guidelines in the Red Book, talks about it as well. And then I just put in the link for the treatment guidelines for pediatrics as well from the AIDSinfo.gov.